Hey everybody, it's Dr. Eric Balkavage. We're back for another edition of the Thyroid Answers podcast. And today we're talking hormones. And we're talking to hormones with Delfina Zelaschi. She is an OBGYN. And you may be thinking, why would you bring a traditional OBGYN on the podcast? Don't we have our issues? Well, look, always keep in mind that medical physicians are not bad people. They have a certain amount of training and they follow their training and their guidelines. They're not bad people. They're trying to do the right things. It's a different approach than functional medicine. But the good thing is Delfina is kind of come to this kind of dark side and is starting to see the light that functional medicine may offer a different approach to helping her clients who have hormone-related issues. So Delfina, we're going to call her Delphi today, or we're going to throw out a whole bunch of names. Welcome to the Thyroid Answers podcast. How are you?
Hi, Eric. How are you? I'm so glad to be here. Really, it's an honor. It's a challenge because English is not my first language, but I'll try to do my best
I
to
think
deliver.
you probably speak better English than our president. Right?
Oh
So
my.
let's go with that. How's that?
Let's not get into that, but maybe, yeah.
So anyway, let's go with this. You're saying, hey, English isn't my number one language, but you speak it fluently. Tell everybody where you're coming from.
Okay, so I'm from Asuncion, Paraguay. I was actually born here actually, my parents are expats. They're from Argentina, and their parents were also immigrants in Argentina. So I've had this long story of a very nomadic family, but we've settled here in Paraguay, and I've studied in Argentina, I've studied in the States, and then I finished my studies here in Paraguay with my specialty. And then after I finished residency, I started gravitating into this whole world of functional medicine, actually, because I was looking for a course or a program that would take me abroad. I wanted to live abroad again. There's this weird spirit in me that wanted me to do that. But then I found out all these online platforms where I could learn about functional medicine. And I actually went into functional medicine because of a personal experience. I was actually my very first functional medicine patient. And that's when I started building up this into my whole traditional GYN practice. And it became today what I do and love, and what has helped my patients a whole lot with their life quality, and has been very, very satisfying to me as a professional. So today I'm trying to put the message out there and get other physicians to really know about this whole new perspective of medicine, because it really has changed the way I practice medicine every day.
But you were trained traditionally. Did your training introduce you to functional medicine? I mean, I don't know how much, docs in the US get introduced to functional medicine in their traditional medical training.
Well, actually, what traditional training left in my body made me search for functional medicine, because I was feeling lousy. When I finished residency, I was not feeling okay. And that's what got me into this whole topic of adrenal function. And we really do not dig into adrenal function as GYN specialists. And even endocrinologists, you have, the two extremes, Addison's and Cushing's, but there's this gray area of adrenal dysfunction. And I was actually going through that myself after residency. And I was unaware of it until I went into all these functional medicine courses and programs. And then when they started talking about this middle ground of adrenal function, is when I started listening to these lectures, and I was like, hey, I've got all these things on the list, and most of my patients do, and they haven't gone through residency, they've gone through different stuff. And that's how I started to incorporate this into my life. So it was actually from what I was feeling that I started to get into functional medicine.
So you're having tiredness, you're having fatigue, and is the issue, and medical school, professional school, lots of time, lots of study, lots of stress, right? Same, I think it would be same there, same here. But in a medical model, were you did you get diagnosed with something? Did somebody provide treatment for something? Or they just said, hey, you're just stressed, or you're just crazy, or you're not exercising, you're not what kind of diagnosis did you get or what treatment did you get that kind of frustrated you and led you to go, okay, something else must be going on here?
Well, I didn't find anything. I searched for thyroid issues. I wasn't having thyroid issues. I actually went to a colleague, she's a psychiatrist, and I asked her to test me for burnout. You know, those tests that they run for you, and if you score such and such number, you're under burnout. I did not score for burnout. And what I was feeling at the time was that it was this ongoing tiredness. I would be on call after I finished residency. I was hired at a hospital, and I would be working on call, and it was this tiredness that would not go away. And I'd love to exercise, and exercise would leave me, totally beat up. I was not energized by exercise. My body composition was different. I started gaining fat tissue around the midsection, which was not usually my case. And I've never even had issues with my body composition. It was never a problem for me. I was losing hair, my skin was dry. And also my mood. What called my attention was my mood swings, or how moody I felt, because that was not me, or how my energy was so low because that was not me. So if there was not a thyroid issue going on, I was not malnourishing myself in general, generally, because I had sugar cravings, which I did not consider that to be an issue. And I was not having any mental health issues. So then what was going on? And I didn't know about this adrenal dysfunction. And when I went into the functional medicine, I realized that, first of all, what they taught me at the time has now evolved into different concepts, or research has shown us that maybe what we thought of as what we first called adrenal fatigue is not actually the best way to term it, because when we refer to adrenal fatigue, which is this gray area of what I was going through, it's actually what I always say, it's a colloquial term. Because if you want to tell a patient, okay, so what you have is a hypothalamic pituitary adrenal axis dysfunction. That's a mouthful. I mean, it's very hard for a patient to grasp. So
It's going right over their head.
I know. So we've given this a term, which is adrenal fatigue, but at the time when I learned about it, we've also been taught that there was this point of adrenal exhaustion. We would go stage by stage. It was this oversimplistic model of, okay, so you're on this stage and your lab work looks like this, and what you're feeling clinically is this, and then you go to the next stage and the next stage until the full adrenal deterioration and the full adrenal exhaustion, which is like sort of like an Addison's situation, only it's transient, it's not permanent. But what we've learned up to now is that this model has changed because of our clinical experience and because of the research. And we've learned that these stages are actually not separated as compartments. Sometimes you can have a patient that is overlapping between stages. You can have maybe lab work that is representative of a very early stage of adrenal dysfunction, and then you might have the clinical aspect of it being somewhat of an advanced stage. So it's not that simplistic, but I'm very glad that we've learned to look at this as a possibility among our patients, because you don't need to go through residency to be feeling this. I mean, you can go through grief, you can go through divorce, you can go through a child with special needs, you can go through a parent that needs to be taken care of because of, I don't know, Alzheimer's or whatever disease that's very invalidating. And that could just take a toll on you and on your adrenals, and you start feeling all these things, and you get, antidepressants. Like you told me, what were the answers you got for this? I refused to take antidepressants. I was not feeling depressed. At times, maybe I did, but what we see is that our patients get treated for individual symptoms, which is okay because you don't want your patient to feel lousy all the time. But there's this underlying cause of adrenal dysfunction that nobody's addressing. And what we found out today is that it is a dysfunction of the axis. The adrenals do not get cortisol depleted, because that's a concept I was taught at the very beginning, that if this is an ongoing situation, you will become cortisol depleted. It's like you will not have any cortisol to get by with anything that comes up in your life. That's not exactly the case. you have a cortisol response, it is not an adequate cortisol response. And it becomes inadequate, even more inadequate, as much or as long as you're even more exposed to that stressor.
So I want to break this down a little bit, right? So to summarize, you go through medical school, go through training, you get out tired, exhausted. The medical model, right, sees no pathology, right? They don't see a hypothyroid condition. They may or may not have tested you for cortisol function. And typically, the way that cortisol is assessed and adrenal function is assessed in a medical model is either a morning or afternoon blood cortisol or a 24-hour cortisol collection, right? Do we make enough total cholesterol or cortisol? And do we have the time I'm measuring it, AM or PM, is there enough blood cortisol? And those were probably, if you got those tested, more than likely, those were within the reference range. And so then it wouldn't be an adrenal issue. And then that frustration, not knowing what's going on, that led you to functional medicine space and saying, hey, there's this thing called adrenal fatigue, which is what we all learned early on. I've been doing this just almost 30 years now. And I learned that too, the adrenal gland fatigues. But that's not truly the case, right? And I think one of the big frustrations or the problems between allopathic medicine and functional medicine is we're looking oftentimes at two different testing strategies, and we see two different things. And so a medical community, if they're running just blood cortisol, I pretty typically I see, even in the person who's chronically tired and fatigued, if they get their blood cortisol done, it's usually normal or high. But if you look at that same person's urine or saliva cortisol, it could be low or dysregulated, right? It could be low or high or whatever, but I don't see that many abnormal blood cortisol levels in people who are tired and fatigued. And so this creates like this kind of, there's not an adrenal issue. I'm looking at the blood, there's enough in the blood. And that same medical community, if they're not looking at really, they may look at total urine collection and may say, that's not bad, but they're not seeing a disease state. They're seeing it in the blood. They're not looking at urine or saliva typically. And so they're saying there's nothing wrong with your adrenal gland, versus the functional medicine community is putting a lot of credence into saliva and maybe the urine metabolites and saying, oh no, my gosh, here it is. So in your mind, as you go from one model into the other model, how do you justify both sides of that as you're looking at somebody and saying, I think this is a person with adrenal function, despite what the blood says?
Well, asking the right questions is what really puts your finger on what's going on, because what we usually have access to here is, first of all, a fasted cortisol, we have a cortisol blood drawn at, excuse me. All right, so what we have here is we have access to morning cortisol through a blood test. And usually that's all we have. So in order to improve the conditions of how this gets done, I usually ask my patients to get the test done at home. They can have a lab come at home and have that done. But as you know, at the moment you're pricking somebody's skin, that can spike up cortisol. That's not a very realistic test. What I'd like to test is these things you tell me, saliva and cortisol metabolites in urine. I do not have access to that all the time. So what I'm dealing with is the situation where I might not have the best lab work to get done with all my patients because either a money issue or an access issue. So asking the right questions is what leads me to the diagnosis most of the time. And there are very evident cardinal symptoms with adrenal fatigue that are very obvious. They might overlap with hypothyroid symptoms, which you can rule out by running a thyroid panel, right? But there are questions you need to ask. The sleep pattern, for example, right? You can tell by the sleep pattern if there's a cortisol issue going on. Maybe the patient can go to sleep, they have adequate melatonin levels when they go to sleep, but then they start waking up at night. They start having these interrupted periods of sleep. Or another pattern is, for example, they sleep through the night and then they wake up at 3, 4 a.m. They can't go back to sleep. That's a very early cortisol surge that they're having. So there's this imbalance in cortisol levels. They have adrenaline and cortisol spiking through the night, and that's just a maladaptation of the axis. You need to start asking the right questions, and you can tell what's going on. Like I said, where are you gaining most adipose tissue? In the midsection, and you start asking questions about lifestyle behaviors, and you can tell your patient does not have a strongly inadequate diet, but it's just a hormone issue. You can tell it's a hormone issue, and you can ask things about their job, about their relationship with their loved ones, things like that. You can detect stressors and the way they interpret stress, and that'll lead you into thinking that maybe this is an adrenal issue. And then you can run the tests that are more elaborate, such as saliva and urine metabolites. But sometimes just by listening to the patients, and that I believe that's what we need to start changing about a medical model. I know how it is. Well, in the States, I know how it is, but here we work with insurances, and then we have like 20-minute visits with patients, and that's a very short time. You cannot address all these issues. You cannot evaluate what's going on with all these stressors, with how your patient manages stress, with their sleep pattern. You cannot ask this full spectrum of questions if you only get 20 minutes with a patient, right? So I think that's very interesting with the functional approach, that maybe you may not have all these fancy tests, but you just need to learn to ask the right questions. And I think what is very useful is that all of us start engaging with this kind of practice. And this is the way we're going to change the medical model. This is the way we're going to approach things in a different way, and maybe stop accepting 20 minutes per patient time slots, right? So answering your question, yes, I like to run urine metabolites. Yes, I like to make, this cortisol curve during the day with my patients. But if I don't have access to that, asking the right questions will lead me into the diagnosis,
Yeah. So, and I think that's important to have a discussion. The story, the signs, the symptoms, they help us indicate, kind of dictate, okay, what's going on here. I think one of the problems is that when somebody has chronic tiredness and fatigue going on, we sometimes assume it's a thing, right? Is it thyroid, or is it adrenal? Is it it's something else that's driving it, right? And we assume it's going to be one or the other. And my argument, it's not one or the other. Mm-hmm. All of the systems contribute probably to that fatigue. So when somebody has weight gain around the middle and they got tiredness and fatigue, I don't know that we necessarily have to differentiate what condition it is. And you and I have had this conversation in the past when we've had a discussion. I think it's part of an excessive stress response, that all systems start to become compromised when we have excessive stress, because we're not in homeostasis anymore. We got too much stress on the system, and we have to down-regulate or shift the metabolism to deal with what's going on. Okay. And from my perspective, when I'm looking at somebody who has adrenal issues going on, I always assume that there's potential problems with thyroid physiology, whether the labs are extremely clear to it or not, because I know that thyroid hormone inside the adrenal gland plays a major role in adrenal hormone production, all the adrenal hormones. And so how could it be that somebody could generate cortisol if I'm going in to get my blood draw done, but yet have a low amount on as I'm taking it through the day with maybe urine or saliva collection? And the answer to that is pretty easy, especially when we think about how adrenal hormone cortisol is made.
I believe there are actually two things going on when we have an adrenal issue and a thyroid issue, that usually these things get overlooked. And it's this thing you always talk about this inflammatory process going on at a cellular level, and also the interaction between the glands. Usually when we try to test for thyroid function, we forget about the adrenals. And remember, cortisol will also block the conversion from T4 to T3. There's an interaction between all these glands. We cannot separate them into different compartments, and we always need to address the inflammatory issue undergoing all these changes, right? Just like you said, if you see a patient that is gaining weight in their midsection, there is an inflammatory issue going on. You cannot overlook that, right? There's a mitochondrial dysfunction, and that maybe is the reason for the fatigue.
Absolutely. And then we have to ask the question, is it broken or is it adaptive, right? And that becomes the next part of the question. But when we think about cortisol production, we have to ask the question, why might it show up low? And one of the reasons is, how do I make it? Right.
Right.
And is it made the same in acute stress as it's made in homeostasis or chronic stress? And the answer is no.
No.
And so we have to keep that in mind. And like when you were talking, like, hey, getting blood is stressful, driving to go get your blood draw done, having somebody stick a needle in your arm, all that stuff can be stressful. We have a typical rise in cortisol in the morning. That's probably a little bit different than how we regulate cortisol in a low stress state through the day. So we have to take all of those things into consideration when we're considering what's going on. So could we have two things going on at the same exact time? I run my morning cortisol test in the blood and it looks good, but then I look at my salivary cortisol or my metabolized cortisol and it looks low. Could that be true too? And the answer is yes, because I already have a cortisol awakening response and I may have stress. In a stressed condition, how does the adrenal gland make cortisol? Well, and maybe I should, if you want to dig in, kind of explain how cortisol is produced, I'll let you do it. If not, I'll talk about it, but maybe I'll just introduce it from in an acute state. So for the listeners, to make cortisol, the base hormone that we use is cholesterol. Okay. So cholesterol has to be brought typically into the adrenal gland, and to get cholesterol out of the blood. So cholesterol is made, most of the cholesterol is made. It's not what you eat. That's important for people to know. Most of it is what we make. We got extra food energy. We don't need to make it into ATP because the cells are good. Then we push it back out of the cell, convert it into cholesterol. Now we can make cell membranes and hormones and neurotransmitters, or just dump it into bile, make bile and get rid of it. But if I want to make cortisol, typically in what we call a homeostatic low stress state or a chronic stress state, what happens is that cholesterol driven around the body in a lipoprotein, and it docks to the adrenal gland in the cells. And then we use this hormone called T3 for those docking proteins to work appropriately. So now we can dump off the cholesterol at the adrenal gland. And now that cholesterol comes into the adrenal gland, and then we drive that into the mitochondria. And at the mitochondria, we convert that into something called pregnenolone. And then pregnenolone can go in different directions, but it can be used to make cortisol. That means you have to have optimal mitochondrial function. And to have optimal mitochondrial function, what else do you need? Well, you have to have T3 to help drive mitochondrial function. But is that the same way we make it in acute stress? And the answer is no. In acute stress situations, the adrenal gland, the adrenal cells can actually make their own cholesterol. They can't make a lot, but in acute stress situations, they've got the ability to make their own cholesterol to make into cortisol. Really, really important. So, hey, I've got this cortisol awakening response. I get this flood. Is that may be able to continue because that's more of an emergency situation. I need to ratchet this stuff up so now I can make some. But during the rest of the day, I've got chronic stress going on. I don't have enough T3 in the cell. I don't have enough T3 being able to drag that in or to run the mitochondria appropriately. And so now I can't make as much sufficiently through the day. So that's how I look at it. You cool with
Yeah.
that?
Yes, I agree with that. And not only that, because we also have other cofactors involved in the process. And it's actually mitochondrial dysfunction is not only a cholesterol issue, but a nutrient deficiency issue. And in order to get the cortisol moving, we need to have these cofactors. There are B vitamins involved. There are, there's selenium, there's zinc, there's vitamin C. There's all these things that also happen when we were talking about chronic stress. This also happens. You get nutrient depleted when you're exposed to chronic stress because there's this high demand for cortisol. All these cofactors get worn out, and you're not replenishing your body with these things. And that also gets us into this wear and tear of the mitochondria. We start producing more free radicals. We're not able to neutralize free radicals, in a proper way because of this selenium, iron, glutathione deficiencies. We're in this state of oxidative stress that it just loops back to the very same place where everything started. There's a high demand for cortisol, an inadequate response of the cell to the cortisol response because the mitochondria are in an oxidative state of stress. So sometimes you can't put your finger on where all this starts. I would say it's on the perception of stress, and then that triggers the cortisol response, which we can afford to trigger at the very, very first stages of it. But when it becomes chronic, what's going on with our cholesterol uptake, what's going on with those micronutrients that are involved in the cortisol synthesis, like biochemically, intracellularly. And then when this becomes even more chronic, what about the free radicals that get produced in the mitochondria, right? Because what cortisol will do is it'll start demanding more ATP production. And with more ATP production, we have more free radical production, right? So we're kind of, I don't know, swimming in this inflammatory oxidative state that we also need to address. Whenever we address adrenal function, we need to address, like you said, thyroid function at the very same time, the perception of stress, but not only that, we need to go into the intracellular level and start supporting all these processes that help us produce cortisol, the cofactors, the free radicals, all those things, much like you say in your book, for example, when you talk about thyroid function and you talk about mitochondrial function, right? If we don't have a proper mitochondrial function, the hormone's going to reach the cell receptor, and what's going to be the intracellular response? It's going to be inadequate, right?
Yeah,
and that translates into fatigue.
I think part of the issue, and which came first, the chicken or the egg? I think part of the down regulation of the mitochondria is an adaptive response, at least at the onset.
Yeah.
Right. And so if we look at, and somebody might say, well, why would that be? If I'm under stress, shouldn't I have increased mitochondria, right? Shouldn't I have those things revving harder to make more energy and to burn more fuel? And the answer for that is, if there's my opinion based on what I've said, and I'm totally open to other opinions, but what I perceive is that if I'm a cell, then I'm perceiving a lot of stress, right? That is going to trigger my defense mechanisms, which part of the defense mechanisms are to increase oxidants and free radicals because they can be used as part of the tool to kill the threat. Okay.
Yeah.
If I upregulate that part of the system, and I also have an upregulation of the mitochondria to work harder, that creates free radicals as part of my cell defense. And it increases a whole bunch of free radicals because as I run the mitochondria, there's exhaust for that, right? So in a normal, for the listener, in a normal homeostatic low stress state, just taking food energy and converting it to cell energy, we call ATP, produces some waste, produces some exhaust, okay? And so is that good or bad? Well, it's part of the process, but the cool part is the cells make a certain amount of antioxidants that naturally balance the amount of waste or exhaust that's coming off the mitochondria. We balance that with an antioxidant system. And what some of the literature shows is that if we have these stressors go on the cell, whether it's physical, emotional, chemical, organisms, the body starts to say, whoa, I've got a threat here. The cells say, whoa, I need to increase my cell defense. And so they need to create more free radicals. And what the literature shows is that at the same time, there's a down regulation of the mitochondria. And we have to ask, is that dysfunction or is that beautiful design? Because if I have a limited capacity to make antioxidants, and I have all the free radicals because of self-defense, plus all the exhaust from the mitochondria revving up, what's going to happen? I'm going to have massive amounts of free radicals and not enough antioxidants to address it. And for the listener, what does that mean? That means you're going to damage and destroy the cells. The cells get damaged to a point where they die. Do we want that? Nope. So beautiful design is say, hey, we gotta make a whole bunch of free radicals over here to do some defense. So let's decrease this exhaust producing machinery. We don't need all that right now. What we need to do is slow that down so that we have enough antioxidants to deal with what we're dealing over here. At some point, it becomes chronic stress and chronic free radicals. That's when we start to see the tables tip a bit and we go, okay, now I'm in chronic exhaustion. Now I have chronic downregulation of the mitochondria. But one of the things I really struggle with is sometimes, and I agree, more stress can deplete micronutrients. But we often sometimes don't see that giving somebody mitochondrial support products to help that, what we call mitochondrial dysfunction, it doesn't work. Why doesn't it work? My opinion is many times we give micronutrients with the assumption they're going to do what we want them to do. I'm going to magically put this in the body. I want that B6, that CoQ10. I want it to go to the mitochondria and I want it to just go in there and fix it. It's
not the way. No, that's not. Yeah.
No,
it's
this naive concept, right? Because it's a micronutrient, it's going to do what we want it to do. The cells and tissues use those micronutrients for what's best for the cell. And so it may be, I don't want that in here because I've got a threat. Maybe I need those micronutrients to make more inflammatory cell defense mechanisms, right? So we have this idea, this naivete that we can direct it, right? And we've seen this in both allopathic and functional medicine, right? We give this allopathic drug and say, hey, we want it to do this. And then we find out, oh my gosh, it's got all these consequences, right? Why is it doing that? Well, because the cells determine what happens to things. The tissues determine what happens to things. We don't always get the say. And just because it's a natural substance doesn't mean we can direct it. Go ahead, give me your
and
thoughts.
That's why I believe what we first need to address are lifestyle interventions.
It's a heresy.
Well, because we reach this point with chronic cortisol exposure, like you said, where our cells are going to prioritize survival mode. You know, they're going to start producing all these free radicals as a defense against the supposed attack that's going on, and they're not going to uptake all these nutrients. So I always tell my patients, it's like we're throwing, I don't know, stupid example, right? Water into a bucket that has a hole in it. But it's not going to work unless you reduce the inflammatory response with the things you can do. And you'll be surprised, because when somebody starts gaining weight, for example, in this context of adrenal dysfunction, what they do is they over-exercise, which is a completely bad idea. That's a very, very first lifestyle intervention. That's actually what I did when I was going through this. And one of the first things I had to do was not to stop exercising, but to bring it down a notch. I did not have to have this mitochondrial exertion because I needed to regenerate my mitochondria, right? So I also needed to fix diet, maybe habits that I was having. I told you I was having sugar cravings, which is very typical in adrenal dysfunction, right? And I had to fix that with macronutrient interventions. I had to switch my macronutrient organization. I didn't do that myself. I did it with a nutritionist, right? But I had to keep these glucose levels stable throughout the day, because the whole point from a cellular standpoint is to reach this mitochondrial homeostasis. I think that's where where things are going to start really changing, when you start changing that, right? A patient is going to really hack their hormones when the mitochondrial function is not in this defensive state. And that takes time, right?
So I guess so the question then is the downregulation of the mitochondria, is what we see with the adrenal, we say it's dysfunction, but is it really dysfunction, or is it adaptation? Because what we're saying is,
it's an adaptation.
Hey, now, does it break in time? Absolutely. Can it break? Absolutely. We can talk about that, but we also have this restorative capacity. But really what we're talking about, and we're going to move right into that because you brought it up, is how do we address it? We've spent so much, take ashwagandha, take this, take that, take all this stuff. And we assume that because I'm giving this thing that should regulate the adrenal gland, that I'm going to fix it. Well, wait a minute. If it's an adaptive response and not broken physiology, it doesn't really matter what you give, because it's not broken. So it would be like yelling at me for not eating when I'm busy fighting off an attacker. Like, if you're screaming at me, why are you not eating? What is wrong with you? Hey, I'm fighting for my life over here. Well, you should eat. Well, that is not important in the moment. I have to save myself, right? So we're going, what is wrong? He has an eating disorder. Well, do I have an eating disorder, or do I just not that's not my priority because I have a threat, right? So I think that's important for the people to hear, because we oftentimes think my physiology is broken. And I don't think it's broken. I think it's adaptive, but we're trying to, it's trying to force your adrenal physiology to do something different. It's like trying to get me to eat while somebody's stabbing me with a knife. I don't care how good the cheeseburger tastes. I'm not going to eat in the moment. I'm going to defend. And so what you started to get into is, how do we address it? It all comes down to us saying, okay, then what is causing the adrenals to have to adapt like this, right? That's my opinion. I could be totally wrong, but I think we're on the same page here, because that's where you went almost right away, was we have to talk about lifestyle factors. Nobody wants to hear about that.
What goes on is that the dysfunction is what we see maybe in a lab, maybe in the symptoms, but what you're talking about is this adaptation that I think it's the most important thing that we need to fix, and the most important conversation we need to have with our patients. And it's so easy, and at the very same time, very challenging for the patient, but it's really what's going to get things going. Like I said, it's what really going to change. For example, things I did when I was going through this, and I apply that with my patients. I was on call, right? So there was this inevitable sleep pattern that was getting disrupted. I just couldn't change that. Maybe you have a baby that's, a newborn, and you can't change that. But there are certain things you can do, which is, for example, trying to really synchronize your circadian rhythm with daylight. That's just very simple. You can do going to sleep every night at the very same time, waking up in the morning and getting yourself exposed to daylight, and then getting some other exposure in like at midday. I tell my patients, go out at midday. You're in the office, you go out for lunch, you sit out there for like 10, 15 minutes, get that sunlight. You don't wear your sunglasses, get that sunlight in your retina, get exposed to that, and then go to sleep as much as you can every day at the very same time, wake up at the very same time. It's an effort. I mean, in South America, we love to party, and you know that, right? So people get, you have these weekdays, parties and whatnot, and that really throws off the circadian rhythm of a lot of my patients. So I tell them that when you're going through this, when you're trying to get out of this, you need to really make the effort to start organizing your circadian rhythm. And that is going to help the adaptive response. That is going to help inflammation. Just sleep changes everything, right? And another thing I had to do personally was also to manage my daily glucose levels, because there's this strong relationship between cortisol response and blood glucose, right? And like I told you, I was having sugar cravings. So this was really, really hard for me. And in some of my patients, I make them wear glucose monitors, and I start evaluating how their diet is impacting their glucose levels, because that is going to have an impact. That is calling for mitochondrial exertion. Again, these are very simple lifestyle modifications you can start doing with your patients. I mean, that is the very first thing we all need to do. Also, there was this other thing, like I told you, exercise. The time of day in which our patients exercise. I always tell my patients, okay, if you can do it in the morning, that'll be great. If you can do it at noon, that'll be great. But some of my patients have no other choice of working out like at 7, at 8 p.m., right? Because that's what they can do. That is not such a circadian friendly kind of habit. But what I tell them is, all right, so you're going to have a sleep routine after that. And maybe not, go through do a dance class, all the cardio, and maybe you can go lift weights, and that's okay. But then have this sleep routine where you unwind the cortisol response after exercise, right? So there are so many interventions. I can start mentioning like a billion of it that I use with my patients, because really using adaptogens, using nutrients, it's okay and it supports these things. But if your patient is not engaging with the lifestyle interventions, we're just not going anywhere, because the mitochondrial demand for mitochondrial, expenditure of, ATP, it's going to be there. It's going to be present all the time. And the release of free radicals is going to be present all the time. Your capacity to neutralize the free radicals is going to be impaired because of this huge demand of cortisol, ATP. It's like this thing that's looping all day long, right?
Yeah.
So, yeah.
Go ahead.
No, just
so I would say for the, a couple things, because I from a listener perspective, they may be listening and saying, okay, balance my blood sugar. And I hear that a lot. And I guess they need to know, people need to know what that means. And then how do you, then the person, so there's the person who doesn't know what that means. There's the person who says, all right, I am craving and eating more carbohydrates than maybe my body can use. And then the third part of that is the person who says, I'm not even eating carbohydrates and you're telling me my blood sugar is too high. Why is that? And I want to get so your take on those things, and then I'll kind of give my opinion if I think it's a little bit different. But that's a frustrating thing for people, because I hear a lot of people when I'm talking to them, they're like, my doctor says I need to stop eating carbohydrates. I'm on a ketogenic diet, and my blood sugar's still high, or I'm exercising, or I am low carb, I'm paleo, and I'm still have high fasting glucose, or I have high glucose through the day. So what's causing that? And what am I supposed to do about it? How am I supposed to regulate my blood sugar? Because I'm not eating much in the way of carbs. And I think that frustrates people because they feel like we're not listening to them when we say, oh, your blood sugar is too high, you need to regulate that. They're like, what the heck else am I supposed to do? So when you see somebody's blood sugars out of maybe, and I guess we can talk about what somebody's labs might look like, or what that looks like symptomatically. How do you explain each of those situations? Terrible diet, blood sugar, low carb diet, high blood sugar.
I get that a lot. I get a lot of patients tell me, but I don't use any sugary stuff in my diet. And it's not a sugar issue most of the time. It's usually a starch issue in the diet. That's when the patient can, for example, like you're saying, I don't eat sugar, and yet I have high blood glucose. Maybe it's the amount of starch in the diet. But what about these patients that are zero carbs in their diet, and they have this high blood glucose? Well, that's when the cortisol comes in, because remember, cortisol is going to want blood glucose available all the time as a mechanism for us to cope with this enormous energy demand that it's putting on us, right? And insulin is going to raise as a response to that. And like I always say, there's this physiological fight between cortisol and insulin all the time, where cortisol always wins, right? If you're continuously stressed out and there's this continuous cortisol demand, there will be an elevated blood sugar level, right? So then it just winds down to the very same thing I said. You need to address with these patients that are not having a diet that is high in carbs. You need to start addressing these lifestyle interventions of cortisol spike management, right?
So let me pose a question to you.
Yeah.
So you're saying, hey, cortisol and insulin, they're fighting against each other in this situation. If somebody's got high blood sugar, wouldn't dropping cortisol physiology be a beneficial thing to get the glucose out of the bloodstream? Wouldn't allowing for more insulin to get it out of the bloodstream be a beneficial thing?
No. Well, it actually doesn't work that way. It's not that simple, right? It's not that simple. What is the scenario? Can you explain more of what you
Yeah,
mean?
so I'm just as you said it, that popped into my head. We're saying, hey, adrenal, now somebody's in this adrenal fatigue situation, but if they got high cortisol, right, that's pumping out blood glucose. It's one of the things we don't want in the bloodstream for high levels for an extended period of time. That is glucose. And so how do we get it out of the bloodstream? Well, typically we think of insulin in a fed state, right? Insulin goes up to help get it down. But that might also be the reason why somebody's insulin is elevated in the fasted state, and maybe a good reason to reduce cortisol anyway. Why? If I've got a stress response going on and I can't utilize all this glucose that you're throwing into the system, I got to manage it. So reducing cortisol, what does that do? That reduces the stimulation of glucagon to that driving up blood sugar. So now I drop that excess of glucose production and I allow more insulin to do its job and get it out of the system. I'm just throwing it out there as a thing to consider and think about, right? Again, broken or adaptive, but this is one of those things where we have conversations like this, we can start to say, maybe that sounds more adaptive than it sounds broken or dysregulated. You see where I'm going with that?
What's going to happen in time is that this, for example, what you're proposing is maybe use insulin therapy to counteract this. No, I know you wouldn't. Yeah. I know you wouldn't, but I'm telling you, what's going on is that we have this insulin response, right? In this whole scenario, we have this insulin response. And what we would logically think would be, all right, get some insulin in there so that it gets pulled into the cell, right? For energy. And that's how this story just loops around perfectly. But like you said, there's this adaptation to insulin. I mean, insulin was useful for us in fasted states, back in the day in the cave era. It was very useful for us for us to manage glucose in fasted state. But what's happening to us right now is that we have these shock waves of glucose in our blood sugar, in our bloodstream, which spike insulin. And the insulin receptor is just like you said, I will not respond to this stimulus if someone's stabbing me at the very same time. The insulin receptor just shuts down. It's not broken. It's just adapting to this situation where there's too much stimulus, continuous stimulus is affecting this. So you can become insulin resistant as a consequence of chronic cortisol exposure.
I think maybe it is all tied together, but I look at it a little different. In that chronic stress state, it's causing cortisol. We have downregulation of the mitochondria, which reduces glucose transport, both glucose or insulin dependent and non-insulin dependent. That I don't look at as a broken physiology, but an adaptive physiology. Why?
Yeah.
Because more glucose in the cell could support the threat. And two, the issue becomes we don't have optimal mitochondrial function, right? We're not driving as much glutathione through that process. We're doing more anaerobic metabolism, right? So I think that plays a role in that insulin and glucose resistance to some degree. There's only so much stuff I can kind of force through the system because of the big machinery is downregulated a bit. I'm doing this more all anaerobically versus aerobically. And so then where does all that stuff need to go? It's going into adipose tissue. It's like, okay, I need all that, but I can't use it all right now. Let me put it into storage. And then, oh, but I need some more now. Do I want to do the work to get it out of storage? No, I don't make that much energy. Okay, let me get some more stuff coming in here. Let me make some more from the liver. And why that's important, what are the two glucose transporters that hold on the longest in a low T3 state, in a low thyroid state? It's glucose transporter 2. And you go, okay, well, what does that do? Well, glucose transporter 2 is what exports glucose out of the liver and transports it into the adipose tissue.
Mm-hmm.
So beautiful design, right? In a crisis situation, low stress, high stress, downregulation of metabolism, what am I still able to do? I am still able to do one of the most important things in a stress condition, and that's generate glucose and put it into the bloodstream. The second most important thing I'm able to do is to get that excess into storage so it doesn't gunk up the machinery too much, right? So I can put it into that adipose tissue. So again, this is kind of nuanced conversation, and some of the listeners may be going, whoa, this is starting to get too deep. But this is the stuff that people like you and me need to have some more conversations with. Not that either one of us is right or wrong or what we're doing is wrong, but I think to some degree, we need to change the conversation around some of these things that we're talking about and look at it. Because I think we sometimes do to clients. I'm not saying you do it or I do it, but I always, we throw out the term dysregulation or dysfunction, right? And I think that makes a person almost think like they're broken. I say it all the time, and I always try and catch myself. And I want people to be thinking more along not dysfunction, it's adaptation. Think adaptation. If you think adaptation, then you don't think your body is attacking you. Then you don't think that you're broken. Because when you think your body's attacking you or you think you're broken, man, that's hopeless. And really where I want to go with the rest of this conversation that we have is I don't, and I don't think you do, want the person to think that they're unfixable. What I want them to do, and I think what you want to do is realize that, hey, that your body's behaving in a way because there's an excessive amount of stress on the system. If we reduce the stressors, instead of putting more time on trying to manipulate the system to work the way we want, that's how we're going to get that's how we're going to win, right? That's how we get the adaptive response to start to go, oh, okay. Just like where I was saying, you made me a meal and you're mad at me because I didn't eat it, and you're trying to figure out different ways for me to get me to eat it while I'm getting attacked. None of those eating strategies, whether you blend it and hand it to me as a shake, whether you cut it up in little pieces and feed it to me as I'm trying to protect myself, none of those methods will work optimally. The best way to get me to eat the meal that you made me is to help get rid of the threat, which is the person who's stabbing me with a knife. Does that make sense?
Yes, exactly.
So let's talk about what creates stressors on the physiology that somebody could start with, right? Because I think sometimes we jump over dollar bills to pick up pennies, right? We want the supplement before we want to change our diet, our lifestyle. So you started on that process with, hey, we got to deal with, let's sleep and wake cycles, right? Let's not be up all night. But what are the simple strategies? That was one of them. Let's kind of look at our habits, look at our behaviors. And one of the most important things that we can do is organize sleep cycles, right? Not being all over. So we talk about that one. You talked about blood sugar regulation. And I think when we have that conversation, for sure, I think my suggestion to most people when they're like, I don't even know what that means, is to focus on eating a whole food based diet. But because people get confused, I don't even know what that means. Like, what is it? Can I eat fruit? Can I not eat fruit? Can I not ever have a carbohydrate? Should I eat carbs? Should I not eat carbs? So I think the initial conversation for me for that is eat whole foods, eat more natural whole foods. Can I eat a fruit? Yes, you can eat fruit. You don't need to eat 20 pieces of fruit all day. And most of us, you eat one apple and you're like, I'm good. We don't eat apples like we eat, dark chocolate kisses or something, right? Those we could eat the whole bag. So what are some of those easy, low-hanging fruit things that you think listeners could do if they've got chronic tiredness, chronic fatigue? Who cares if they've been diagnosed with adrenal fatigue, whatever? What are the
Whichever might be
foundational things, right? Regardless of what condition. I don't have adrenal fatigue. What should I do to be healthier? What are some of those foundational things?
Well, if I try to walk my mind around the whole day of a typical patient, what I always ask them is, first of all, what you do when you first wake up. Like I said, do you check out your phone? Do you get exposed to blue light, right? Do you get exposed to daylight? It's very important for them to understand that you need to start off your day with this light exposure, first of all, right? Always try to start off your day at the very, same hour if you can. Even I tell my patients, even try to do it on Saturdays and Sundays. And then coffee. Coffee is this, you crave a lot of coffee when you're going through fatigue, of course, right? But we need to start to sort of taper down the coffee exposure in our patients with fatigue. If it's an adrenal issue, if it's a thyroid issue, if it's a mitochondrial issue, we sometimes don't ask our patients how many cups of coffee they take during the day, right? And what I tell my patients is that maybe if you can't go by without that morning coffee, well, you can do that, but then try to do, as you're recovering from this, try to take as least as possible, right? Because it spikes up the cortisol stimulus that we're trying to manage in a physiological way. So also, that also what's the composition of breakfast? Like you said, it's whole foods. Okay. So people sometimes I take my green smoothie, and the green smoothie is mostly fruit and not as many veggies, and there's no fat or protein in their breakfast, and that just spikes up blood sugar, right? So maybe they have this misconception what's healthy and what's not. That's why nutritionists are crucial in functional medicine, right? And
Let me
then
be devil's advocate there, because I know
yeah.
here's the question I got. Somebody told me I have adrenal fatigue,
Mm-hmm.
and I should have a cortisol awakening response.
Mm-hmm.
So if I have adrenal fatigue, why wouldn't I want to have caffeine in the morning if it's going to increase my cortisol? Why wouldn't I want to have all this sugar in the morning? Because my cortisol is not working as well as it should. So shouldn't I consume all that sugar to get my blood sugar up? Isn't that what my cortisol is supposed to do in the morning?
Well, that's exactly what we're not trying to do. We're trying to lower the demand of cortisol on the gland. We wanted to make it as physiological as possible. What has brought us to this situation is this constant demand, this overriding of the gland, right? So when I went through this, I was just unable to deal with a single bit of stress during my day, right? Just one thing dropping on my to-do list was a catastrophe in my brain, right? So now what I can do is, all right, so I have this stressful situation. Stress is just part of life. It's going to happen. There is going to be stimulus for cortisol release every single day of your life. But when you're recovering from this fatigue, we need to really wind down on the stimulus of cortisol, of the mitochondria, of as much as we can. That's why I talked about exercise. Exercise is good. Exercise is great. Going for a jog is awesome, but it's demanding too much on the axis that is at this moment maladapted. It's not responding adequately at this moment, right? It's not like you're never going to jog again. It's like you're never going to exercise again. Because when I was going through that, I was like, I love to work out, and I was like, yeah, so I'm never going to work out ever again. I'm always going to feel tired after I work out again. No, I had to go through this process. I went through a 6-month process where I would just slow down. I continued to work out, but I did not jog. I just walked. Exercise is good. We need that stress on the mitochondria, and we need the cortisol response to happen only in a physiological level. And at this point, when you're first recovering, you're not on a physiological level. Your response is inadequate. So when real stress, so when coffee comes, you'll have this cortisol response that is actually overriding your system because you are unable to respond adequately. But what if later on you have a meeting at the office and it's a very stressful meeting, something went on with one of your kids or something like that, the axis is going to be exhausted. It cannot deal with this anymore. That's in colloquial terms, that's what's going on. We have a cortisol response.
But I'm playing devil's advocate, but that's why I need the cup of coffee, because it keeps me from being tired and exhausted. So why is that bad? Right? I mean, but this is real life conversations, right? People say, listen, I need the caffeine in the morning because I can't get going. I agree, right? Or at 3 o'clock in the afternoon, I cannot keep my eyes open. I need the caffeine.
That's an inadequate cortisol response when you feel that need.
And doesn't stop me from going to sleep at night. So I don't agree with what you're saying, right? That's what somebody's going to say. Now, I'll give you my answer, but yes. There's a lot of people, especially if they've they've used the caffeine as the crutch. Now, I'm not opposed to somebody having a coffee or caffeine. If you can have a cup of coffee and have some caffeine and you do well with it, I think that's great. But those are the things when people talk about needing their caffeine, doesn't stop them from going to sleep. So I don't know why it's a problem. It doesn't do that for me. I could drink a cup of coffee at night before I go to bed. Why are you saying it's a problem? And I need it to get through the day. Why would you the person's going to be like, why are you taking that away from me? Right?
Well, why do you need it in the first place? You know, that's
I'm
that's
exhausted.
well, that's it. That's
So
it.
I'll
We
give you,
need to. Okay.
so let me give you my take. And this is for the listeners. Again, I'm not telling you what to do for yourselves, but here's why I would tell somebody why we have to tailor back on it, right? Caffeine is an adenosine. It blocks adenosine action. That's what caffeine does. It blocks adenosine from binding to receptors. Adenosine is the base of something called ATP, adenosine triphosphate. What we've been talking about the whole time is when we're talking about blood sugar and glucose, it's trying to use that food energy and to make cellular energy. If I'm not very good at making ATP because I've got downregulation in my mitochondria, got oxidative stress, then what happens is I am chewing up the ATP faster. And now I'm left with this base molecule called adenosine. And adenosine is when it binds to receptors, it tells the body, whoa, we're shutting it down. We need to be in sleep mode. So when you are tired and fatigued, and I'll let you jump in and give your opinion on this. A lot of times, my opinion is that the reason they're tired and exhausted is you're waking up in the day with a lot of adenosine that didn't get converted back to ATP. And so let's make up a number just for simplicity's sake. Let's say you make 100 ATP when you have a good night's sleep overnight. The listeners, this is not real. I'm just making it up so it makes it easier. So you start the day with 100 ATP, no adenosine. But let's say you had something that disrupted your sleep last night. Now you didn't have time to rebuild all that adenosine into ATP. So now you start the day with 50 adenosine and 50 ATP. And so you wake up tired and sleepy because you still have these sleep hormones in circulation binding to receptors. So you're tired and you're sleepy. And you do what? You grab your cup of coffee, your caffeine, and guess what it does? It blocks that adenosine from hitting the receptor. And now you're like, well, now I'm not as tired. And it works. And I agree it works. The problem is you still have what? Adenosine in circulation. So as the caffeine starts to wear off, and the half-life is like 12 hours or something, that adenosine starts hitting receptors, and it's now 3 o'clock in the afternoon. And not only do you still have the 50 molecules of adenosine you started the day with that kept you sleepy, but you've also used up some of that ATP that you had built. And so now maybe you have 75 adenosine molecules and only 50 or 25 ATP. So now you're really sleepy. So what do? You reach for your cup of caffeine and you drink it down and you wake up a little bit. Why? Because the adenosine can't bind to the receptors. And so you're exhausted, right? Or so it wakes you up. And now you get through the day and you say, all right, that doesn't bug me. I'm so exhausted. I'm going to fall asleep. And you go to sleep, right? And you then wonder, you go to sleep because adenosine is not the thing that tells your brain it's the signal time to go to sleep. That's melatonin. So melatonin has risen through the day. It tells the brain, hey, it's time to start shutting down. But you have that caffeine that's got the 12-hour half-life that's still in circulation, not allowing for deep quality sleep. And now you have disrupted sleep quality through the night, which then causes you to wake up the next day without that ATP rebuild, and it starts that cycle all over again. And to me, many people think that their chronic tiredness and fatigue is an adrenal issue and they're trying to that. I think the bigger issue for a lot of people is the adenosine component. And that's why we have that back and forth with caffeine. It helps, but then it disrupts sleep. So now I don't rebuild my ATP into adenosine.
Exactly.
So I think for a lot of people, that is one of the number one reasons to help your chronic tiredness and fatigue is we got to limit the amount of caffeine, definitely no caffeine in the afternoon, because it definitely impact your sleep, right? And then two, one of the things I think, and I'd love to get your opinion on it, one of the best things, in my opinion, that we can start to help people with that fatigue factor is get them some creatine. And
Yes.
creatine, because it's the phosphate donor that we use to make ATP, and if we're not good, 40% of a process in the body called methylation goes to making creatine. So
Yes.
40% of this methylation process that a lot of people struggle with, especially in chronic stress, goes to be making this end product called creatine. If we can give people creatine, then they have the phosphate donors that they can rebuild their ATP, and they're probably going to have less tiredness and fatigue through the day, which then they can feel less need for consumption of caffeine, and then they can start to sleep better, and then that builds the cycle. So have you looked at any of that?
Yes, I actually
What's your thought
used it with
process?
my patients. It has helped me to, at the very beginning, I tried to slow down the exercise amount that they do, or the hours or the intensity. But with the use of creatine, I was able to, with my patients, to reintroduce them to their regular exercise that they love to do without this post-exercise exhaustion. That's what they felt clinically with the creatine, but on a cellular level, that's what's going on. When you said that, that's exactly what's going on. So basically, I didn't want to get that technical. I didn't know I was allowed to, but yes, basically that's what caffeine is doing. It's again, everything comes down to the mitochondria, right? It's overriding the mitochondrial function in a non-physiological way, right?
Yeah, so I know I want to respect your time, and we got stuff to do, and I've got about 2 more hours of questions to go through. I'd love the
Wow.
conversation, so we could just keep chatting, but we're going to wrap this up. The good news is that you've actually started to create a course that's kind of helps people understand adrenal physiology a little bit, right? Can you talk a little bit
Yes.
about that?
I've created a platform. It's an online platform where, well, it's women's health specialists, but specialists from any specialty. I have family doctors, I have dermatologists on it, I have endocrinologists, but a lot of nutritionists. And it's this functional approach to women's health in a Spanish platform, right? We don't have that much access to these things in Spanish. So it's a platform it's my name, it's delfinazelaschi.com, or you can follow me on Instagram, and we are launching courses and small modules of educational content that you can access and add that up to what you're doing in your daily practice. It's short courses, very down to what's going to be useful with the patient, with all the fundamentals, but and all the scientific backup. But it's good, it's practical, it's what you're going to use with your patients, and it's really an introduction to functional medicine from a practical standpoint and from women's health standpoint. So that's an ongoing little project that I have that has started just this year. So, it's building up.
So it's more of a practitioner course, not so much the layperson
Yes.
course. But
Yes, we might release something for the layperson, but for now it's only practitioners.
okay. And so we have the podcast, crazy as it sounds, has listeners all over the world, obviously. And maybe that's how we got met, maybe hearing
Yes.
the podcast, right? So it's pretty cool that you see when I look at the map of where all the listeners are, you're like, my God, how do they even know? I only know one language, right? So you wonder, how do they listen? Do they really understand what I'm saying? I don't know, but they must.
Yes,
They're
we all
obviously,
do.
everybody gets different. I think we're the only country that doesn't do a great job of learning other languages. So
But your
anyway,
podcast has really provided valuable content. I always talk about your podcast with my students, with my colleagues. It has very, very valuable content, really.
well, I appreciate that. And I enjoy the conversations. That's why I keep kind of stretching the length of the conversation, because we're just kind of getting into it. I had a whole bunch of questions on women's hormones, birth control. I had all that questions to go yet. So we didn't even
We can
get
do it
there.
next
So
time.
we'll get you back again. We'll have another conversation. We'll start talking about one of the biggest problems I think we've done to women, my opinion, is this total disregard for what a healthy menstrual cycle should be. And so I think that needs a good hour and a half in itself. And we can have a discussion about maybe some of the challenges that we've been doing or creating as a result of not really educating people that, oh, this is what it should be like. If it's not like that, you have a problem, versus just saying, hey, we're going to manage these issues with these hormones. So that's a teaser. We'll come back and get that. If somebody wants to find out more about you, you can go to your website. You'll send me the links for all that stuff, but
Yes,
where can they go? And you're on Instagram, right?
I'm
So
on
tell them where they can
Instagram.
find you.
It's at Delfina Zelaschi, just like my whole name is spelled. And it's all Spanish content, but I guess you have Spanish listeners, so Spanish speaking listeners. So everybody can enjoy that. It's for patients and for professionals mostly, but everyone can get something valuable of it, I guess.
Awesome. Well, I appreciate you coming on the Thyroid Answers podcast. It was a great
Thanks,
conversation.
Eric.
For the
Thank you so
listeners,
much.
this one got a little bit heavy, but I like to go a little bit deeper and get some stuff. And I like the fact that we get to have that more in-depth discussion and kind of challenge our thinking a little bit. Every time when I'm hearing people, my brain starts going like, well, what about this? Like, what about that? So it was a great conversation. I look forward to having you back on the podcast again. Have a
Thank you.
fantastic day. Okay.
You too. Bye-bye.